I would like to invite our last speaker, Dr. Suganeswari, for giving us again, I think, a very interesting talk on minimal vitrectomy. How to attach it? It's such a
Marks up.
Exactly I'm going to be talking about. We are going to be talking about only a part of the trauma. This is called retinal incarceration. What new do we know about it? So coming to traumatic retinal incarceration. So this is a topic which is like something which is not everybody is aware about. The first one, yeah. So what exactly happens in a traumatic retinal incarceration? There are too many things that we should understand, that some terminologies may be overlapping terminologies. When we talk about traumatic incarceration, I'll be coming to that in a short while from now. So what new is what we are going to be talking about in the traumatic retinal incarceration. So posterior segment injuries, as we all know, has vitreous loss, incarceration of the vitreous, the retina, the choroid, progressive scarring. This is most important thing what we should understand. Shortening of the vitreous and the retina. We have better understanding of the diseases nowadays, so we know what to do, when to act. And tears at the incarcerated site. So what is traumatic retinal incarceration? Prolapse of the vitreous, uvea and the retina into the scleral wound. This is called traumatic retinal incarceration. Now the mechanisms, I am not going into it. Now this is not something new. The classification of retinal incarceration, this is not new, but that's something which we have all forgotten, which we are revisiting today. So what is class 1? Class 1 is anything in the posterior zone. Posterior zone means it's the region which is going to be posterior to the vortex vein ampulla. 1A means macular involvement, which means it is within the 2 disc diameters of the fovea, you have an incarcerated wound. 1B is no macular involvement, which means it spares the central 2 disc diameters. And what is class 2? It is equatorial zone. So which means the region from vortex vein ampulla to the aura. This is called the equatorial zone. And when you have an incarceration at the anterior zone, that's coming to class 3. It's the region anterior to the aura. Now, if you have an incarceration at these levels, it's very important that we know where exactly we have to plan our plan of management. Now, how do we diagnose a retinal incarceration? So, retinal incarceration is diagnosed by ophthalmoscopy if you have a clear media. If you have a hazy media starting from the cornea up to the vitreous, so in that case, corneal clarity is not there, or you have hyphema, or you have a cataract, or you have a vitreous hemorrhage, then we don't have a view. So then in that case, we need to do the ultrasonography. So here there is an ultrasound which you are all seeing. So what exactly do we see here? You can very clearly appreciate the vitreous tracking into the retina. So this is what it is. And then intraoperative visualization of the fundus is important. So now what is the timing of surgery? We all know the timing of surgery is a balance. That is not a static value. Please remember, there is no standard rule that you have to be taking the patient only on this time. No, you will take the patient when your inflammation settles and the engorgement of the eye is coming down and the risk of developing a closed funnel retinal detachment is not there. So you have to time your surgery in between these two things. Ideally speaking, 10 to 14 days after trauma is what we have all learned and we all know. And the factors which helps you in making a decision is whether or not you have an IOFB, what is the nature of foreign body, metallic or vegetative. Then in that case, your vitrectomy has to be very early, or presence or absence of endophthalmitis. So these dictates when you will time your surgery. What do we have in terms of understanding of an incarceration? The incarceration of the fibrovascular proliferation, what does it do? It produces shortening of the retina, and it prevents the contact of the retina with the RPE. So what are the goals of surgery? You relieve the traction by islanding. So we have to island, that's what is the principle. Removal of the scaffold, every scaffold has to be removed, and you have to excise the peripheral retina if you have an incarceration at the periphery to preserve the function of the posterior retina. What is the choice of procedure? The advantage of vitrectomy is removal of the blood and the other pathogenic stimulants which can hinder the wound healing, and it includes the vitreous scaffold, the proliferating cells, and the serum products. What is the procedure in detail? You complete the vitrectomy with a posterior hyaloid removal of the vitreous from the incarcerated site to minimize the subsequent proliferation and the traction, removal of all the membranes, whether it is the epiretinal or the subretinal, placement of the endodiathermy, that is to demarcate the desired area and also to have a good hemostasis. Now, where do you place the retinotomy? This is what is most important. If you have an incarceration in the class 1, then you will have to place your retinotomy as a circumscribed retinotomy. If you have a class 3, then your circumferential retinotomy is what is going to help you, and this is performed so that the posterior of the incarcerated site to allow the repositioning of the displaced retina into the more posterior location against the RPE. Now, how do you make the retinotomy? You may use a scissors or a vitrector. Some of us may even use a flute. That's personal choice of the surgeon. And how do you minimize your retinotomy? You must be as close as possible to the incarcerated site in small increments. You don't go zoom past in that, go in slow segments. So to minimize the size of the resulting retinal defect. So this is where it would vary from when you are performing an RR for in a PVR case in a rhegmatogenous retinal detachment, that's going to be different. That we are all taught large is better, but here the small is better. Now, what and how do you proceed? You attach the retina now with whether you use LPFC or you're going to use your gas tamponade, the air tamponade, and then the margins of the retinotomies are treated, then you use a tamponade gas or oil. So now this is the same fundus of the patient whom I showed you the ultrasound. So the ultrasound is very, very classical that you should be able to identify on the ultrasound. Now here I'm going to show you two cases which I've operated. This is a case 1 wherein it's a 9-year-old male with history of blunt trauma, the break at the infratemporal quadrant with the vitreous incarceration. So here it's only the vitreous into the subretinal space. So what do you do? The choice, there is no buckling here. It's only the vitrectomy with a belt buckle with an endo laser with a gas. So you may ask, why not a scleral buckle? It's a peripheral break. Yes, if you use a scleral buckle in this particular patient, you are going to have herniation of the vitreous gel into the scleral wound. That's why you're not going to be using a buckle on that. So now coming to case 2, it's a 52-year-old male, injury with a tree branch, came with hyphema cataract. So now on the ultrasound, you are seeing the vitreous into the retina into the choroid. So this is what you should understand when you have an incarceration of these tissues. What we do is we try to island. I told you island, and the retinotomy has to be close because you are having it very close to the fovea. So we have to island it here in order to attach the retina. So that's what we have done. Now, what are the complications of an extensive relaxing retinotomy? Hypotony, epiretinal membrane, large field loss, a PVR with recurrent retinal detachment, extensive ischemia leading on to neovascular glaucoma. So now coming on to what is new then in these things. BTEP, what is that called? Beyond the edge proliferation. So after a relaxing retinotomy, what we get is called as beyond the edge proliferation. One must be very cautious about this. Why does this occur? Because the proliferation is anterior and it is contiguous with the relaxing retinotomy. It is an unusual, but it is called one of the types of proliferative vitreoretinopathy. Now you must all understand that here OCT comes into easy help for us to identify or rather delineate or understand the structures better. So what I have written here as AR means it's an attached retina. So you can see that's a good attached retina over there. And the mark which I have given it as yellow TS, it's a traumatic schisis which is there. And then the RR points to the site of the relaxing retinotomy edge which is attached in this patient, and beyond that BTEP is there. You have the beyond edge proliferation. After that you see the bare RPE, which means now this is the separation which has come. So these are the things which are the trouble after you operate on a patient with a retinal incarceration. How early do these BTEPs occur? As early as 5 weeks. And then what is the cause? It's posterior-anterior traction, and the location, inferior interface between the aqueous humor and the silicone oil or the gas. So you may be wondering, why am I telling aqueous humor in the posterior chamber? Once you remove the vitreous, there is no vitreous over there. It's all the aqueous which fills in. So what is the reason? Compartmentalization, the concentration of blood, the RPE from the areas below the RR is the cause for this. Now you should also know that we should be able to differentiate the BTEP from what is called as SIRF. What is SIRF? It is nothing but the severe inferior retinal folding. So what we see in these patients are like your RR edge is going to retract and come away, your laser scars are going to be lying bare over there. So this is what happens in this, but this happens in a rhegmatogenous retinal detachment. So next thing is relaxing retinotomy age fibrosis. This is when you have membranes which are there, epiretinal, which can cause contraction and thereby providing the fibrosis. So you will have to differentiate this from BTEP. What next? So if your PVR is the causative factor for all this BTEP, what do you want to do? You would like to do a chorioretinectomy, in which circumstances perforating globe injuries with an exit wound at zone 3 or zone 2, severe IOFBs. What do we do in this? Removal of the incarcerated retinal tissue from the underlying choroid to the level of the bare sclera. So you remove all these tissues in toto, 360 degree around the impact of perforating site of the foreign body using a vitreous cutter. So this is what I've done for this patient. Inferiorly you can see the margins of the chorioretinectomy. But believe me, when you do this, you will have to be as early. Like Dr. Natarajan pointed out, it has to be done within 100 hours of the primary surgery. If delayed, it's very difficult to perform this. So it is performed in the perforating eyes so that you may prevent the PVR related complications. So to conclude, the period between the primary repair and the vitreoretinal surgery is very crucial. It is not one single value. It has to be well titrated by monitoring the patient and take the call when you can do a safe surgery. That is what is important, not doing surgery but a safe surgery. And equatorial or peripheral incarceration, you may support it with buccal. The size of the retinotomy is directly proportional to the site of the tissue incarceration. Anatomical restoration depends on extent of retinotomy. The vision depends on the location of incarceration. So this is what I have for all of you today from Shankar Netralia. Thank you for your patient time today. Thank you.